Morning. Morning. May mga hinintay ba bang classmates? Okay. Morning. How do you start the day? Do you usually have a prayer or as a UF? I can read the prayer. Sa UP kasi ako walang prayer.
Let us all remember that we are in the holy presence of God. In the name of the Father, and of the Son, and of the Holy Spirit. Our Father in heaven, we, the AF community, consecrate ourselves to the cause of truth, that in all our aspirations we may contribute to the greater good. Born from the heart of the Church, grant us the commitment to serve, promote dignity of every person, and build an authentic human society. May we constantly strive to become mabuti, magaling, at may malasakit sa kapwa, that we may attain total development of humanity for your greater glory. Amen. In the name of the Father, and of the Son, and of the Holy Spirit.
Stand up naman. Okay, so our topics for this morning, no? So yung 8 to 10 lecture and then the 10 to 12 lecture are medyo a bit far from gynecology. No? So the first part, parang neurophysiology. So, kailangan natin awake kasi may mga receptors, acetylcholine, mga ganon. So, stretching muna. Ha? Stretching. Hands up. Okay. Forward. Side. Okay. Okay. Tapos hips. Okay, tapos yung second part, yung pelvic organ prolapse, more on anatomy also. Okay? Okay. Hindi ka pa nag-stretching. Nag-stretch ka na? Okay. So the first lecture is on lower urinary tract function and disorders. No? So the reference for this lecture is from your comprehensive gynecology. Okay, so as a review, the central nervous system consists of the brain and the spinal cord, di ba? It's divided into the peripheral nervous system, which is also divided into the somatic and autonomic nervous system. So the somatic system, remember that it is under voluntary control. So for example, sa urinary tract, it connotes to the striated external urethral sphincter. So kung striated siya, skeletal muscle under voluntary control. So as opposed to the smooth muscle ng urethra later. And then the levator ani muscles. Levator ani muscles in yung pelvic floor muscles. That's what we contract when we teach yung Kegel exercises or yung pelvic floor muscle training. So, somatic yon, voluntary control. And then the autonomic nervous system regulates the visceral functions such as detrusor, or detrusor is the bladder muscle, contraction and relaxation. So yon, involuntary control. Okay? And then the autonomic system consists of the parasympathetic and the sympathetic nervous system. Diba? Sympathetic nervous system is the fight or flight, diba? Response. Okay. So to discuss the physiology of micturition, remember that micturition, yung pag-ihi, is both voluntarily and involuntarily controlled. Okay? So although the bladder is innervated by the autonomic nervous system, there is a high degree of voluntary control that can be exerted on it. For example, hindi naman kayo biglang iihi on your seats, di ba? Kasi there is voluntary control of the bladder. there are well-established neural connections from higher neural centers to the bladder, so such as the control of the cerebral cortex. Therefore, the neural control of the bladder function is quite complex, and any neurophysiologic defect from the cerebral cortex to the bladder can result in bladder dysfunction. So the sympathetic nervous system, di ba, fight or flight, it promotes urine storage. Example, may humahabol sa'yo, di ba? Hindi ka na maiihi while running. So, it promotes urine storage. In contrast, the parasympathetic nervous system controls bladder contraction to effect voiding. Okay? Okay. The sympathetic efferent nerve fibers, so remember that they originate from the T11 to L2 level. It innervates the beta receptors. So T11, so sympathetic T11 to L2, it innervates the beta receptors on the bladder and the alpha receptors in the urethra. So since storage yung function niya, di ba, sympathetic nervous system, to store the urine as opposed to empty the urine, okay? So ang effect niya is bladder relaxation through the beta receptors and contraction of the urethral smooth muscles, okay? And then the parasympathetic nerve fibers, they travel through the S2 to S4 ventral gray matter via the pelvic nerve. So S2 to S4, pelvic nerve, and then muscarinic receptors. So since parasympathetic, it causes voiding or detrusor contraction through the muscarinic receptors. Okay? And then yung somatic efferent nerve fibers, so somatic voluntary control. It innervates the urethra through the pudendal nerve. So S2 to S4, somatic, pudendal nerve, tapos urethral striated muscle, kasi somatic, no? The urethra has a smooth muscle and striated muscle component. And then the striated muscle is under voluntary control. And it is active when the person tries to prevent or stop urination. Di ba pag umiihi tayo, when we void, pwede natin stop, go, stop, go. That's a function of the striated urethral muscles. Okay, so the two phases of micturition, the storage phase and the emptying phase. Okay? The storage phase lasts for several hours. Di ba? Pag tulog nga tayo, kahit 6 hours. Storage phase ng bladder. And then the emptying phase, which lasts for a few seconds. Coordinated contraction and relaxation of the muscles in the bladder and urethra is required for the two phases to happen. So, when the bladder contracts, the urethra should relax. Or when the bladder is relaxed, the urethra should be contracted. No, storage phase yun. So, during the storage phase, the sympathetic and somatic reflexes are activated while the parasympathetic is inhibited. So the red ones, yan yung active. And then yung black, inhibited. Okay? So sympathetic tsaka somatic during storage. Okay? So the sympathetic nervous system causes bladder relaxation through the beta receptors. And it causes urethral smooth muscle contraction through the alpha receptors. So, naka-relax, naka-contract. And then, inhibited yung bladder contraction. Okay? And then, stimulated yung urethral striated muscle contraction through the somatic nervous system. Dito. And then, during the emptying phase, inhibited yung nasa black. So, inhibited yung sympathetic nervous system. So there is no bladder relaxation, no urethral smooth muscle contraction, and no urethral striated muscle contraction. Therefore, no contraction of the urethra. So naka-relax, naka-open. The urethra is open. And then there is bladder contraction through the muscarinic receptors via the parasympathetic nervous system. Okay? So you just need to remember which systems are activated and inhibited and what receptors and yung function nila. Okay? So remember this na lang. Okay. So, the receptors naman, so acetylcholine is released from the postganglionic parasympathetic neurons. And then, they activate through the M3. Di ba muscarinic receptors, I said, parasympathetic causes bladder contraction. So, acetylcholine yung doon. And then, norepinephrine and epinephrine are released from the postganglionic sympathetic neurons and they bind naman to the alpha receptor and beta receptor. So, yun naman yung sa sympathetic nervous system. Okay? The alpha 1A subtype predominates in the urethra. Okay, and then beta 2 and beta 3 receptors cause the trusor relaxation. So ito, this is the urethra ha, yung bladder outlet. Yung bladder contraction, yung detrusor muscle. Itong alpha receptor, nasa bladder outlet kasi siya, so urethra na itong function niya. Okay? Okay. So for the clinical correlation, so because of complexity and extensive involvement of the nervous system, a host of systemic disease process, including neurologic disease and direct trauma, in addition to medications, can affect lower urinary tract function. So, for example, diabetes. So, di ba sa diabetes, there is parang desensitized yung mga nerve endings. So, there is also what you call the diabetic cystopathy, wherein there is sensory neuropathy. So, the patient does not feel that the bladder is full, when in fact, full bladder capacity na. Dahil nga desensitized yung receptors niya. So, there is resultant bladder overdistension. For example, normally at 500-600 ml, full bladder na tayo. Okay? Pero for these patients, they do not feel the fullness of the bladder. Hence, they will keep storing the urine. There will be overdistension. Sometimes 800 ml, 100 ml, dun pa lang sila maka-feel ng bladder fullness. And there could be detrusor overactivity. That means the bladder keeps contracting. So they will have frequency in urination. Parang balisaw-saw, ihing-ihi sila. Okay? And then, processes involving the brain and central nervous system such as stroke, traumatic brain injury often result in loss of bladder inhibition with the detrusor overactivity. Diba we said that there is central control of voiding. So for example, even if nafe-feel na natin na naiihi tayo, we control it with our cerebral cortex. So patients with stroke or traumatic brain injury, nawawala yung inhibitory process of the cerebral cortex on the bladder. That's why they have the detrusor overactivity. So may sariling control yung bladder. Contraction ng contract. There's no inhibition from the cerebral cortex. Okay? And also, in spinal cord injury, the resulting symptoms will depend on which level of the spinal cord injury, the degree of the injury, whether partial or complete, and the age of the injury or how long the injury has been present. With pelvic surgery naman, di ba, you have lectures with oncology. There is radical hysterectomy. Sometimes there is damage to the pudendal and pelvic nerves. This can also cause urinary retention, and which is a known complication of radical hysterectomy. So parang nade-denervate yung detrusor muscles. That's why there is no contraction, there will be retention. Okay? Or high residual volume. When you void, ang dami pang natitira. Okay? Okay. So in summary, normal bladder function requires the bladder to accommodate an increasing volume of urine at low pressure. So it should accommodate or expand with increasing volumes of urine without increasing the pressure. So nag-increase yung volume but the pressure remains the same. That's a property called accommodation. Okay? And then it should have appropriate sensation and no involuntary contractions. Okay? And then the bladder outlet, it should remain closed at rest and stay closed with increases in intra-abdominal pressure. So the urethra should remain closed kahit mag-increase yung volume ng bladder. And even with increases in intra-abdominal pressure, for example, nag-cough tayo, there is increase in intra-abdominal pressure. That increase is transmitted to the bladder pressure. But the urethra needs to remain closed. Otherwise, kung nag-increase ng pressure yung bladder, yung urethral pressure is low, mag-open siya. Maiihi tayo pag umupo tayo. Okay. And then, the bladder must also contract in a coordinated manner with adequate strength as the bladder outlet resistance decreases. So, pag nag-contract naman siya when we void, it should contract with an adequate force, coordinated with relaxation naman or opening of the urethra. Okay? So, yun yung function niya. So, this requires an intact local and spinal reflexes and an intact central nervous system. Okay. Next would be the anatomy of the lower urinary tract. So, ito female anatomy pa ha. So, walang prostate. The bladder consists of the bladder body above the ureteral orifices. So, ito yung ureteral orifices. So, this one, yung triangle, is the trigone, di ba? Formed by the ureteral orifices and yung junction ng urethra and the bladder. Or the urethrovesical junction. So, this one, so on top of the orifices is the bladder body. Okay. The continence mechanism in women centers on the proximal urethra and the urethrovesical junction. So this part. Diba ang urethra sa females is only 3 to 5 centimeters short or long. So as compared to the long urethra in males. So actual closure of the urethra is produced by the involuntary internal sphincter at the bladder neck and the voluntary external sphincter. And also by the mucosal coaptation of the urethral submucosal vascular plexus. So, ito, yung urethral smooth muscle, so involuntary control. And then the striated urogenital sphincter, and then the submucosal plexus. Tapos, it is also attached anteriorly by the pubourethral ligaments, pubourethral, so pubis, pubic bone, and the urethra. And then laterally by the urethropelvic ligaments, so urethra and the pelvic walls. Okay. So pudendal nerve injury as a result of prolonged labor, imagine yung mga patients na prolonged labor, they can have resultant sphincteric weakness. Okay? Kasi there is injury to the pudendal nerve. So, there could be incontinence after difficult vaginal delivery. Okay, so the musculofascial support of the urethra is also important for continence. So, as I said, the urethra is attached anteriorly to the symphysis by the pubourethral ligaments and laterally to the arcus tendineus by the urethropelvic ligaments. So the anterior vaginal wall, when intact, it also provides posterior support and compression of the mid-urethra. Diba? The urethra lies on the anterior vaginal wall. So pag may defect din sa anterior vaginal wall, nawawala din yung support ng urethra. Okay? Okay, so therefore, continence relies on the internal, external sphincters and the supporting ligamentous attachments of the urethra. So, diagnostics. Now, so for patients with urinary symptoms, you need to do a complete history. So, including urologic and gynecologic history, medical history, and current medications. Kasi diba, as we said, may mga medical conditions, systemic conditions, neurologic conditions that can have urinary symptoms. For physical examination, it should include a vaginal inspection and evaluation for pelvic organ prolapse. For laboratories, you need to do a urinalysis and urine culture because the presence of white or red blood cells and bacteria may suggest urinary tract infection, nephrolithiasis, kidney disease, or even a urinary tract malignancy in rare cases. Okay? Have the patient accomplish a bladder diary or a frequency volume chart. A bladder diary is a simple, inexpensive way to obtain information about the patient's fluid intake, voiding habits, voided volume, and incontinence episodes. Mamaya pakita ko sa inyo. If the patient is complaining or feeling of an incomplete bladder emptying, so sabi niya, pag umiihi siya parang may natitira or incomplete bladder emptying, you are considering possible urinary retention. What you would do is you would take a post-void residual volume. So paano gawin yon? A woman with a full bladder, so full bladder, ihing-ihi na siya, you ask the patient to void. Then within 10 to 15 minutes, the residual volume in her bladder is measured, either by inserting a straight catheter into the bladder or using a bladder ultrasound or bladder scanner. The post-void residual or yung volume na natira after niya umihi. A large post-void residual suggests urinary retention. So that is either from an inadequate bladder emptying or detrusor underactivity. Ibig sabihin, hindi nag-pump ng mabuti yung bladder niya. Or bladder outlet obstruction, sa urethra naman may problem. Or a combination of the two. Okay? Do a cough stress test, so cough stress test to determine urine leakage through the urethral meatus. So, the patient is lying down and then you ask the patient to cough. So pag nag-cough siya and then may leak of urine through the urethral meatus, that is diagnostic of stress urinary incontinence. Yung minention ko sa inyo na with increase in intra-abdominal pressure, there is involuntary leakage of urine. If the cough stress test naman is negative, pero sabi niya talaga sa'yo, nagli-leak siya. For example, nagsusumba siya, lagi niya kailangan mag-napkin or diaper kasi may leakage siya talaga with exercise or gano'n. So if it is negative, you may perform a 1-hour pad weight test. So 1-hour pad weigh. You weigh the pad prior to the test. So for example, napkin, i-weigh mo siya. After that, you have the patient walk around with the pad for 1 hour. And then, i-weigh mo ulit yung pad. Re-weigh the pad. If the difference is more than 2 to 3 grams, then that's considered positive for stress urinary incontinence. Okay, this is an example of the bladder diary, where the patient would need to record the amount and volume, the amount and timing of her fluid intake. So, na-note niya for 24 hours. And then yung urination niya, ino-note din. What time nag-void? How many ml? Nagkaroon ba ng accidental leakage? Was there a strong urge to void? And what are the triggers? So for example, makita mo, running, or coughing, or sneezing, dun siya may leakage pala. Okay? So that is bladder diary. So another evaluation would be office cystometrics. So, it is a urodynamic test in which you insert a catheter through the urethra. Now, the catheter is left in place and it is attached to an asepto syringe without the bulb. Pour the sterile saline into the syringe and measure the amount of saline that first causes the woman to have the urge to void. So, i-fill natin yung... So, empty yung bladder, di ba? Oh my God. Hello. So, empty yung bladder. And then you fill the syringe with sterile saline. And then you ask the patient, may nararamdaman na ba siya? Naiihi na ba siya? So, you're able to determine the volume that connotes the first sensation to void, the maximum desire to void. So, nanote natin. So the first desire to void normally occurs at 150 to 200 ml. Okay? Yun yung, for example, umiinom tayo, una nating naramdaman na naiihi na tayo. Okay? Pero when we do something else, ganyan, nag-attend na ng lecture, nawawala yung desire na yun. So usually at 150 to 200 ml. And then the strong desire or strong urge to void, it usually occurs at 400 to 500 ml. Yun yung ihing-ihi na. No? Pero hindi ka maiihi in your seat. Strong desire lang. No? Wala pang urgency. Urgency is yung ihing-ihi na. Kailangan na pumunta sa banyo. That's urgency. Okay? If during filling, the woman reports urgency and then the column in the asepto syringe rises. So usually, di ba parang bladder pressure kasi yung name-measure niya. So yung level dito is stable. Okay? Pag nakita nyo na the fluid level rises or nagpa-fluctuate, there is increasing pressure in the bladder. So that connotes loss of accommodation. So either there is detrusor contraction, involuntary detrusor contraction, such as in overactive bladder, or in bladders na non-compliant. Example, those patients who undergo brachytherapy or radiation, they have radiation cystitis, there is fibrosis of the bladder. So for those patients, there is loss of accommodation. The bladder does not stretch. So when you fill the bladder with liquid, there is increasing pressure in the bladder. Okay. Other more complex diagnostics would include a pelvic floor ultrasound to check for pelvic organ prolapse or hypermobility of the urethra. So they measure the position of the urethra at rest and the position of the urethra during Valsalva. Okay? And then a multi-channel urodynamics can also be performed. It assesses bladder and urethral function. So in multi-channel urodynamics, so pressure volume study siya, there is a probe inside the bladder, so it's able to measure the vesical pressure or the bladder pressure. There is an abdominal pressure and there is a detrusor pressure. Okay, so it's like an ECG tracing of the bladder. So in overactive bladder, you can see that the detrusor pressure increases. May contraction siya. Parang yung intrapartal monitoring, if there's contraction during labor, makikita natin dito yung pressure. So, another test that you could do is cystourethropy. It allows direct visualization of the urethra, bladder, and ureteral orifices. So, endoscopic findings on cystourethropy include anatomic abnormalities such as bladder and urethral diverticulum, urethral strictures, duplicated ureters, the presence of inflammation, foreign bodies, urinary tract stones, or malignant lesions. Okay. So next part of the lecture will tackle lower urinary tract pain and its common causes, including acute bacterial cystitis, bladder pain syndrome or interstitial cystitis, and urethral diverticulum. Do you have any questions for the first part pala? So, physiology, anatomy, so yun, sa exams, you need to memorize talaga the which systems are active, what are the receptors, what are the nerves. Okay, so acute bacterial cystitis. So in short, parang UTI, urinary tract infection, is very common. You need to learn this in OB kasi most patients will go to an obstetrician. Okay? If they have symptoms of UTI, they don't necessarily go to a nephro or an internal medicine specialist. or a urologist. Usually they go to an OB for female patient. Okay? So as many as 50% of women develop UTI at some time during their life. So sa lahat ng girls dito, 50% magkakaroon ng UTI in their lifetime. And by age 70, as many as 10% of women will have recurrent UTI. So remember the symptoms. They include frequency, urgency. What is frequency? Frequency is balisaw-sa, mayat-maya naiihi. Or in a strict definition, it's more than 7 daytime voids. Okay? More than 7 daytime voids. Urgency is the strong desire to void that is difficult to defer. Ihing-ihi ka na, hindi mo mapigilan. That is urgency. Strong desire to void that is difficult to defer. Okay? Dysuria, so painful urination. Suprapubic pain, pyuria, may pus doon sa urine, hematuria. Okay? So dysuria is a highly specific symptom. Okay? So of all the symptoms, dysuria yung highly specific for acute cystitis. With more than 90% accuracy for UTI in young women. So in young women without vaginal discharge and vaginal irritation and no risk of STDs, kung nag-complain sila ng dysuria, 90% baka UTI siya. Okay? Basta no vaginal discharge, no vaginal irritation, and not at risk for STIs. Baka lang siya, UTI. And then symptoms of flank pain, rigors or chills, nausea and vomiting, and fever, they should raise concern for okay. So, flank pain, rigors, nausea, and vomiting, and fever should raise concern for pyelonephritis. So, it's not only sa cystitis. So, the most common organism is E. coli in 80 to 85%. However, a myriad of organisms including Staphylococcus saprophyticus, Enterobacter, Klebsiella, Pseudomonas, Proteus, Streptococcus faecalis, Enterococcus, and Chlamydia can be found. The presence of bacteria in the urine or bacteriuria does not necessarily prove clinical infection, okay? Remember that. Hindi porke binigyan ka ng urinalysis result na may bacteria, you diagnose the patient with urinary tract infection or acute cystitis. Bacteriuria is fairly common in women, especially older women. So if they have no symptoms, ang tawag doon, asymptomatic bacteriuria. It is defined as organisms present in the urine that are not causing symptoms or illness. Okay? Cumulative data from several studies have suggested that 20% of women older than 65 years old will demonstrate bacteriuria. Treatment for asymptomatic bacteriuria is not recommended, even in older women or people with diabetes. So exceptions, ito lang yung mga kailangan yung i-treat na asymptomatic bacteriuria. So treat asymptomatic bacteriuria in women undergoing an invasive genitourinary procedure if the patient is pregnant, diba? Because at risk for preterm labor, has renal transplant, or has incontinence, and if the incontinence resolves with treatment. Okay? Otherwise, do not treat asymptomatic bacteria. Okay. Next. The female urinary tract is vulnerable to infections due to the following reasons. So, makita nyo naman mas common ang UTI in women than in men. Okay? And the reason is because of the short female urethra, allowing easier access of bacteria to the bladder. The proximity of the vulva, vagina, and rectum to the opening of the urethra. Diba? Yung vagina may normal organisms, yung rectum, usually may E. coli. So, yung proximity nun sa urethra, it predisposes women to acute bacterial cystitis. And then, the effect of sexual intercourse with increased inoculation. So, makikita niyo yung patients with, or women with first sexual contact or sexual debut, usually doon sila de-develop ng urinary tract infection. So, sometimes ang tawag doon is honeymoon cystitis kasi kasi during the first contact sila nagkakaroon ng cystitis. No? Okay, and then the effect of contraception and the effect of estrogen loss on the genitourinary tract of older women. Diba? With menopause, there is loss of the lactobacillus and the normal acidity or acidic pH of the vagina. This predisposes to opportunistic infections. Okay? So, after menopause, the vaginal pH rises, so nawawala acidity. This may alter vaginal flora, allowing for the loss of protective species such as Lactobacillus crispatus and the colonization of uropathogenic species, especially E. coli. Okay, so remember this slide, it's always asked why women are predisposed to urinary tract infection. Okay, so we talked about acute uncomplicated cystitis. So in this slide, it's acute bacterial complicated UTI. Okay? UTIs are classified as complicated when there are comorbid infections and conditions with factors that may increase colonization and may require a longer treatment course. So example, there is an underlying urologic abnormality. For example, may vesico-ureteral reflux siya, ganon. Or meron siyang stent, okay? Presence of a foreign body such as catheter or urinary calculi, mga may nephrolithiasis, urolithiasis. Obstruction of urine flow. For example, there's a myoma or pelvic organ prolapse that's obstructing yung urethra niya. Diabetes mellitus, spinal cord injury, which results to a neurogenic bladder, yung mga post-stroke, then kasama. And then pregnancy, and renal transplantation, and the presence of a multi-drug resistant bacteria. Okay. So, having 2 of the 3 acute symptoms. So, ano yung symptoms ng UTI na 3? Dysuria, frequency, and urgency. Okay, dysuria, urgency, and frequency. So having 2 of the 3, in the absence of vaginal discharge, this has a 90% probability of having UTI. Okay? Additionally, testing a clean catch midstream urine sample can be helpful. So ito yung urinalysis. It should be clean catch and then midstream. Pyuria should always be seen in the urine when UTI is present. So, dapat laging may pyuria. And then, it is said that having more than 10 WBC per high power field is very sensitive with a 95% sensitivity but with a low specificity for UTI. Next is the presence of leukocyte esterase. So, dun sa urinalysis, for example, may mga relatives kayo, papacheck nila yung urinalysis nila. Huwag lang kayo mag-focus doon sa pyuria. Don't just look at the pyuria. Look at the other components of the urinalysis. So, leukocyte esterase, it means that there are white blood cells present. And it has a roughly 75 to 80% specificity and 85% sensitivity for UTI. Yung nitrites naman, wala kayo ng positive or plus or negative. Nitrites indicate that certain gram-negative bacteria have converted nitrate to nitrite. And it is highly specific but not sensitive because it only occurs in gram-negative bacteria. So for example, nakita mo nitrite positive, o baka gram-negative E. coli, most common. Okay? And then hematuria, microscopic or gross, is common in acute infections. And its infection is the most common cause of hematuria. So for patients, for example, may mga annual pre-medical examination, ganyan, nagpapa-urinalysis sila, sometimes may RBCs. If there's also WBCs, baka from UTI, you treat the infection first before doing further workup such as CT scan, KUB ultrasound for women. And then, squamous epithelial cells. So more than 15 to 20 squamous epithelial cells. This suggests contamination of the sample. Therefore, a sterile straight catheterization may need to be done for a urine specimen to be collected na not contaminated. So, the following are current recommendations for the empiric treatment of acute uncomplicated UTI in non-pregnant premenopausal women without pyelonephritis. So, nitrofurantoin monohydrate or macrocrystals twice a day for 5 days, or trimethoprim sulfamethoxazole double strength twice a day for 3 days, or fosfomycin 3 grams as single dose. Okay, so ito yung mga according to sa sa GYNE. Diba, usually in our setting there's also cefuroxime and then nitrofurantoin. So in GYNE ito siya. So usually yung treatment ng uncomplicated 3 days to 5 days is okay. Pag kasi complicated UTI, sometimes 7 to 10 days. Okay? And then note that even though fluoroquinolones, yung mga ofloxacin, levofloxacin, although they are highly efficacious, they should be avoided in acute uncomplicated cystitis because resistance is rising and because of the concerning side effects from fluoroquinolones. And then recurrent UTI, it is defined as the presence of UTI 3 or more times in a year or 2 or more in 6 months. So sometimes kasi patients will complain, Doc, may recurrent UTI ako. But when you ask them, yun pala, once a year, ganyan, once or twice a year, they just say recurrent because naulit. Okay? So you need to clarify how often it occurs in a year or in 6 months. Okay, any questions for acute cystitis? Okay, so yung next is bladder pain syndrome or interstitial cystitis. So this is a very difficult na disease kasi patients are parang it's a lifetime parang ganon, lifetime disease that patients need to live with. Okay? So bladder pain syndrome, originally called interstitial cystitis, is a poorly understood chronic pain syndrome of unknown cause. So it's characterized by genitourinary pain and voiding symptoms. It is also a diagnosis of exclusion. That's why it's very difficult to diagnose and to treat. So the International Continence Society defines bladder pain syndrome as persistent or recurrent chronic pelvic pain, pressure or discomfort perceived to be related with the urinary bladder, and at least one urinary symptom is present, such as urgency or frequency in the absence of an identifiable pathology. So, chronic pelvic pain related with one or more bladder symptoms. So, for example, yung pain ng patient is every time naiihi siya, may pain. So, pwede mong i-classify as bladder pain syndrome. Or yung chronic pelvic pain niya, it's also related to frequency. Okay? Or urgency. Pag naiihi siya, kailangan na niyang umihi kasi otherwise ang sakit-sakit na, may hypogastric pain. So yung bladder pain syndrome. So the diagnosis of bladder pain syndrome can be difficult, often resulting in misdiagnosis and delayed diagnosis. It is a diagnosis of exclusion, and many conditions present with similar symptoms. Because bladder pain syndrome is a chronic pain syndrome with no clear cause, there is no cure. And the goal of patient management is symptom relief and improvement in the quality of life and functionality. So often, multimodal therapy has a greater chance of symptom improvement. So itong mga listed lang is yung mga first-line treatment, second-line treatment. Ito mo, first-line treatment nga is stress management, di ba? So, patient education, ganyan. So, hindi siya talaga like, itong drug na to, inumin mo, ganyan. So, medyo mahirap talaga to treat. Okay? And then second line, PT. And then yung oral medications is not that proven naman din. And then bladder instillation nitong light. Imagine mag-instill ka ng lidocaine sa bladder, di ba? It's recurrent yun, paulit-ulit. Kasi mag-wear off din yung effect nun. So, okay. So yun yun. Difficult to treat and diagnose. Last is yung urethral diverticulum. Okay? Itong urethral diverticulum, parang it's often overlooked or undiagnosed. No? So, For example, baka ngayon nyo lang siya narinig, no? Pero it is quite common. So some patients may complain recurrent UTI, never na pelvic exam. And then when you do the pelvic exam, they have pala a urethral diverticulum. Pero they're just always treated with antibiotics kasi yung symptoms niya is quite similar to symptoms of UTI. Okay? So a urethral diverticulum is a periurethral cystic structure filled with urine and connected to the urethra. There are a variety of causes such as congenital, traumatic, or inflammatory. They are diagnosed most frequently in the 3rd to 5th decade. So, reproductive age group, di ba? So, usually nga UTI talaga yung diagnosis. Urethral diverticula are urothelial mucosal lined sacs. So, urothelium yung covering that lie outside the urethra within the periurethral fascia and lack a surrounding muscle. So, ito siya. Okay. So, the female urethra is a short tubular structure surrounded by periurethral glands. Now, the proposed pathophysiology is through repeated infection and subsequent destruction of the paraurethral glands. So, infection, there is destruction of the gland, so nagkakaroon ng abscess formation. Okay? These obstructed glands rupture into the urethral lumen. So, nagkakaroon ng connection. They rupture into the lumen such that they remain as outpouchings of the urethra. So inflammation may lead to malignant degeneration into adenocarcinoma, transitional cell carcinoma, or squamous cell carcinoma. So ito yung itsura niya. Urethral diverticulum. Nasa urethra, akala mo pelvic, akala mo vaginal mass, pero it's actually a urethral diverticulum. Okay? So, urine stasis causes repeated urinary tract infection. Di ba doon sa previous picture, kita mo, pwedeng magstay yung urine dito. Okay? And then, magiging focus siya for infection kasi may stasis ng urine. Okay. And can also cause calculus formation. Ito, naging patient ko to. Imagine, dahil doon sa urethral diverticulum, nagkaroon na siya ng stone. Tapos, dahil dun sa stone, nagkaroon na rin ng fistula, nag-erode siya into the vagina, nabutas na yung covering dun sa vagina. So imagine, if you take out this stone, yung urine niya maglilik lang dito. Diba? Kasi may opening siya. Okay. So women with urethral diverticula often present with a history of recurrent urinary tract infection, stress urinary incontinence, or incomplete emptying. So the classic symptom triad is composed of post-micturition dribbling. So dribbling, ibig sabihin nakaihi na siya, tumayo na siya, pero may pumapatak-patak pa. Kasi yung urine na nag-stasis doon sa diverticulum, siya doon pa lang siya lalabas. Tayo niya. So dribbling yon. Dysuria, painful kasi parang may obstruction, di ba, doon sa urethra. And then dyspareunia, kasi tender yun, inflamed siya. So pang may sexual contact, there is dyspareunia. Other symptoms may include urgency, urge incontinence, frequency, or even a protruding vaginal mass, so palpable mass. Okay. As these women present with a myriad of symptoms, it is critical to perform a thorough history and physical examination. Included in a standard history are questions related to urinary incontinence, irritative voiding symptoms such as frequency, nocturia, urgency, and dysuria, and obstructive voiding symptoms such as poor urine stream, difficulty voiding, hesitancy, or double voiding. Double voiding yung nakaihi na siya, uupo siya ulit para umihi. That's called double voiding. Okay? A focused genitourinary examination is performed with the patient in a lithotomy position. A half speculum, this one. So yung posterior plate ng speculum is placed in the posterior vagina to expose the anterior vaginal wall. The urethra is palpated in attempts to express purulent material via the meatus or to evaluate for suburethral masses or tenderness. So imagine ito, this one, you palpate, when you press on the urethral diverticulum, there is egress of pus or urine through the urethral meatus. So that's your clue na hindi siya vaginal mass because you're able to express liquid through the urethral meatus. So ibig sabihin, may connection siya with the urethra. Na? Okay. However, not all suburethral masses are urethral diverticular. So yung differential diagnosis for these are extensive. It includes a urethrocoel, Skin's gland abscess, Gardner's duct cyst, ectopic ureterocele, vaginal wall inclusion cyst, or a vaginal leiomyoma. Okay, so traditionally, a positive pressure urethropy or PPUG was used for the evaluation of the female urethra. So it's a double balloon catheter inserted in the urethra. So one balloon catheter inside the urethra and one outside the urethra. So both balloons are inflated with fluid and then contrast is infused into the channel between the balloons. So you can see kung merong urethral communications. Okay, so may dye that is infused. Although there are diagnostic benefits to a PPUG, this study has become less popular because of patient discomfort, invasiveness, and infrequent performance in radiology departments. So yung alternatives ito, transperineal ultrasound, it is a non-invasive screening technique for urethral diverticula. The main limitation of ultrasonography is that it is highly technician and operator dependent. So another study that you can do is a magnetic resonance imaging or MRI, where a fluid-filled diverticulum is seen as a high signal intensity sac, while the soft tissues of the urethra have a low intensity. So high intensity siya, and then the surrounding structures have low intensity. So ito yung diverticulum. Ito yung urethra, and then may dalawa siyang outpouch. So parang Mickey Mouse, no? So ayan. Okay. And then, MRI provides a superior examination for surgical planning by accurately delineating the extent of the diverticulum. Okay. Patients who do not have significant symptoms may be observed and treated with antibiotics or anticholinergic. Anticholinergic for yung mga overactive bladder. Kasi di ba acetylcholine yung nagkakos ng bladder contraction through the muscarinic receptors. So anticholinergics, it inhibits yung bladder contraction. Okay? Surgical management involves excision of the diverticulum sac followed by reconstruction of the periurethral fascia to prevent recurrence and urethrovaginal fistula formation. So excision of the sac and then reconstruction of that fascia. Okay, next. Urinary incontinence. Urinary incontinence is simply defined as involuntary loss of urine. Okay, involuntary loss of urine. So for example, yung patient sabihin lang, hindi na nila makontrol yung pag-ihi nila. Or naiihi na sa lawal. Or kailangan mag-diaper, there is pad use. So there are several types of incontinence, including stress incontinence, urgency incontinence, mixed urinary incontinence, overflow incontinence, continuous incontinence, and nocturnal enuresis. Ang memorize na lang dito is stress incontinence, urge incontinence, yung mixed. Okay? So, after this lecture hindi na pwedeng incontinence lang. When you ask your symptoms to your patients, what type of incontinence? Okay. Doon palang level up na kayo. So, stress incontinence, it's the involuntary loss of urine with physical exertion that causes increase in intra-abdominal pressure, such as exercise, cough, or sneezing. So, pag tatanong nyo, pag po ba umuubo kayo, bumabahin, tumatawa, may lumalabas po bang ihi na hindi nyo mapigilan? Okay? Yung stress incontinence. Okay? Urge incontinence naman is the involuntary loss of urine associated with urgency, or the sudden compelling desire to pass urine, which is difficult to differ. So, for example, yung patient sabi niya, naiihi siya, pag ihing-ihi na siya, hindi siya nakakaabot sa banyo. So, there's urge to void, pero hindi niya na-control. Yun yung urgency incontinence. Diba? Kita niyo yung difference ng urgency incontinence with stress urinary incontinence. Kasi difficult yung pathophysiology nila and difficult yung treatment. Kaya kailangan silang ma-differentiate. Mixed urinary incontinence naman means that there is a combination of both stress and urge incontinence. Overflow incontinence is the complaint of urinary incontinence in the presence of an excessively full bladder. Example, yung mga patients with diabetic cystopathy, di ba? They have over-distension. So because the bladder is so full and they do not feel the urge to void, nagkakaroon na sila ng leakage. Okay? Or yung mga post-stroke patients, ganun din. There is bladder distension, no urge to void, no bladder contraction. Overflow incontinence yung tawag doon. Okay? It can happen because of the trusor underactivity, or the bladder is not contracting, or the bladder outlet naman is obstructed, or a combination of both. Basta there is full bladder. And then overactive bladder, it's a syndrome defined by urgency, with or without urge incontinence, usually associated with frequency and nocturia, in the absence of UTI. So that's overactive bladder. May urgency, with or without urge incontinence, with frequency, nocturia, no UTI. Okay? Ayan pala siya. So, yung stress incontinence with increased intra-abdominal pressure, may leak. Yung urgency incontinence, naiihi na siya, may signal na naiihi siya, may leak. Mixed is a combination. And then, overflow incontinence, dahil hindi nag-empty, umaapaw na lang siya. There's overflow of the urine. So, we talked about stress incontinence versus urge incontinence. So, the management for stress urinary incontinence, in which there is urine leakage from the urethra with increases in intra-abdominal pressure, the intervention would be to improve the urethral pressure or minimize the intra-abdominal pressure. Diba? Kasi stress urinary incontinence happens when the abdominal pressure exceeds the urethral pressure. So yung intervention, either decrease mo yung intra-abdominal pressure or increase mo yung urethral pressure. Okay? So pelvic floor muscle exercises or Kegel exercises. So it focuses on training the large levator ani muscles and the external urethral and anal muscles. So ito yung mga striated muscles. It is the most commonly prescribed intervention for the management of SUI. And then pessaries or incontinence pessary, ito yung example. They are primarily prescribed for patients with pelvic organ prolapse. It is a silicone ring device with a knob, placed in the vagina. The goal is to stabilize the urethra, to eliminate hypermobility, and to increase the urethral pressure. Parang stopper. Pag-put ka ng stopper dun sa urethra. And then, weight loss also reduces the intra-abdominal pressure. So, ito naman for the intra-abdominal pressure. And then, estrogen increases the vasculature and mucosal seal. Di ba, we talked about yung continence mechanism ng urethra. Kasama dun yung vascular mucosal plexus. So, you can also give estrogen therapy to increase the mucosal seal of the urethra, thereby increasing the urethral closure pressure. And then one drug that has been used off-label for SUI is duloxetine. It was initially approved by the FDA for management of major depressive disorder. It is an SNRI that stimulates pudendal motor neuron activity. So, di ba, pudendal nerve, which causes the urethral sphincter contraction or rhabdosphincter contraction. Although off-label use yun ng duloxetine. So, another management for stress urinary incontinence is surgery. It is prescribed when conservative treatments have failed. So, surgery aims to address the mechanism of stress urinary incontinence. Ang mechanism niya kasi is intrinsic sphincter deficiency or weakness of the sphincter or yung urethral hypermobility. Diba? We talked about the ligament to support of the urethra. Pag may damage yun, hypermobile yung urethra. Okay? The most commonly used are the pubovaginal slings or mid-urethral slings. So, di ba, kung may damage yung urethral ligaments, hypermobile siya, so nag-floppy-floppy yung urethra. We can use a pubovaginal sling or tension-free vaginal tape. So, pubovaginal slings, these are autologous slings, so harvested from the patient. They are strips of fascia that are placed under the proximal urethra and attached to the abdominal wall to compress the urethra. Yung namang tension-free vaginal tape, synthetic mesh naman sila. So, no need to harvest from the patient. They are placed in the mid-urethra. So, the goal is to increase the urethral pressure. Okay. Difference naman niya with urge incontinence. Diba? Yung stress incontinence, exercise, therapy, estrogen, weight loss, and then surgery. Yung urge incontinence, no need for surgery. No, usually non-surgical yung treatment. You begin with behavioral management through fluid management. So, ililimit mo lang yung fluid intake ng patient. Avoid bladder irritants such as caffeine-containing drinks and bladder training. Bladder training such as time voiding. For example, yung patient, schedule mo siya, iihi siya every 2 hours. So, kailangan na i-hold, every 2 hours lang siya pwedeng umihi, i-dictate mo sa kanya. Okay? Medical management may be initiated along with behavioral management. And commonly used drugs are antimuscarinics, di ba sabi natin kanina, inhibits acetylcholine, such as solifenacin and oxybutynin, or beta-3 receptor agonist. Di ba beta-3, nandun siya sa sympathetic nervous system, causes bladder relaxation. So, agonist siya. Okay, so it increases bladder relaxation. Ito naman, anti-muscarinic. Yung muscarinic receptor causes bladder contraction. Tapos anti siya nun. No? And then for the procedures, third-line options could be posterior tibial nerve stimulation, sacral neuromodulation, or Botox. Pwedeng mag-Botox sa bladder. Kung contraction na contract, di ba yung sa Jotox, pag tense yung jaw muscles mo, lalagyan mo ng Jotox para mag-relax. So sa bladder, pwede din bladder Botox to relax the trusor muscle. Okay. Other types of incontinence include extraurethral incontinence such as yung mga fistula. No? May leak na not through the ureter, pero may leak ng urine, sabi. For example, yung patient, status post hysterectomy, tapos sabi niya ngayon, lagi na siya nagda-diaper, nagli-leak yung urine. Pero hindi sa urethra dumadaan yung leak. May fistula pala siya. No? Yung overflow incontinence, we talked about it. And then functional incontinence. Functional incontinence, for example, yung mga lola na bedridden or naka-cane, hindi sila umaabot talaga sa banyo kasi nga ang tagal bago sila makarating. So, it's incontinence due to limited mobility. And so, do you have any questions? Okay, walang questions. Sige, CR break muna kayo, 10 minutes bago yung next lecture.